welcome to EULAR TV, live from EULAR 2022 Congress at Copenhagen. My name is Mrinalini Day and I'm an academic rheumatology trainee based in Liverpool in the UK. It's so great to be back in person for this Congress after 3 years away doing virtual events. And it's great to be meeting old and new friends alike, some of whom I've got with me here in the studio. We are your EULAR TV team for the Congress, and I will let everyone introduce themselves.
Great. Thank you. So I'm Chris Wincup. I'm a consultant rheumatologist specialising in lupus at King's College Hospital in London.
Hello, my name is Serena Fasano. I am a Rheumatology Research Fellow at the University of Campania, Luigi Manvitelli, based in Naples, Italy.
Hello, my name is Mert Öztaş. I'm working as a rheumatologist in Istanbul Research and Training Hospital.
And we have one final member of the team, Rudi Shukla, who is a clinical research fellow at the University of Manchester in the UK. Unfortunately, he can't be with us today, and you'll find out why a little bit later on. So to start with, we are going to be talking about some of the many sessions which we have attended on this first packed day of the Congress. Quite varied sessions, actually. And to start off with, Chris, could you tell us maybe a little bit about the lupus-related sessions that you've been to today?
Thank you. So as I'm sure everyone knows, it's a really exciting time for lupus research at the moment. And I had the opportunity earlier today to talk with Professor Martin Aringer, one of the authors of the classification criteria proposed by EULAR and ACR for classification of patients with lupus. He was also heading up a Meet the Expert session, which was a very small session. I was very glad to be able to speak to him and get some of his thoughts, which we were able to show people who were not able to attend. So here's my interview with him from earlier today. Great. So welcome to this interview. I'm delighted to be joined by Professor Martin Aringer.
Hello.
He's going to be speaking to us at the conference about classification criteria in SLE. Thank you very much for joining me today. Welcome to EULAR.
Great joining you here, and it's great to be again on the Congress.
Yeah, fantastic. So first of all, I'd just like to ask you, why are classification criteria important for lupus?
So I think the question is, lupus is difficult to define. It's really a complicated disease. Some of the data we have from the criteria say that every patient is really different. So the mix of symptoms, of antibodies, of organ manifestations is really individual. And now that is a challenge which has been tackled very well from the ACR criteria on in the end, but you need to have the right population. If for a clinical trial, for another type of study, you mix lupus too much with, let's say, RA or Sjögren's, it might mean that it doesn't work out in the trials. That's the main issue. The other issue is, and that's a bit tricky, classification is not the same as diagnosis. So of course you are entitled to make a diagnosis if you don't fulfill the criteria, and you are not forced to make a diagnosis if you fulfill the criteria. But it's clear that it shapes our gestalt, our vision of the disease, and therefore it does enter into diagnosis as well. And I think diagnosis is in the end the even more challenging thing, because you have to deal also with the very rare situations which you can never depict in a classification criteria set.
So I'd just like to ask you a bit about the EULAR ACR classification criteria that you published a few years ago. What was the need and what were you aiming to do to develop these new criteria?
So there was a couple of things. One is we needed criteria that were sensitive, and in that regard the SLIC criteria were great, but still needed to be specific. And there was a bit of an issue. And as I said, that is an issue for clinical trials. You don't want to have, in addition to the classification criteria, then other things you have to fulfill to get into the trial. The second thing is we were not entirely happy with early disease and picking up of early disease. And the third thing, and that was from a whole group of people, the feeling was that this 1, 2, 3, 4, and that's it, was not really depicting what we did in clinical routine. And weighted criteria did make a lot of sense. We also had the feeling from the start, ANA are a very good screening test, but the problem with ANA is it has zero specificity. So it shouldn't be treated the same way as anti-SM or anti-DNA or lupus nephritis. Doesn't really make sense. And that's where the onset ideas on how to do it. There was also a push to have a big, also European part in that, which was the first time to come from the EULAR side as well. And we were really happy that both EULAR and ACR were willing to go with that and support this project.
Great. So I think one of the really interesting things, having read those guidelines, was the positive ANA. And I know there's an awful lot of authors, and as you mentioned, from various different places. In terms of having the ANA as kind of the first step in that criteria, I imagine that must have been several heated discussions. And can you give me a little bit of insight into how you kind of came to that and what the overall consensus was?
These discussions are in fact ongoing. But so the issue was, you have a parameter that is highly sensitive and it's anywhere between 97 and 100%, but it's not specific. So it did not make much sense to put it on par, as I said, with the more specific criteria. The other side is we didn't want to get rid of the concept of ANA. That would have been another option, but I think we need that as a teaching tool to have the group of connective tissue diseases together. We need that as a screening test. If a general practitioner thinks about connective tissue diseases, I want him or her to do the ANA. So if we get rid of them in the criteria, that would be a bad thing. And therefore, we said we use it the same way we do in clinical routine. You don't say somebody has lupus because she is ANA positive. But if it's there, you go to the next step. If it's negative, it makes it very unlikely. Now, there's a couple of issues. There's places where ANA testing seems not to work pretty well. And then you have more false negative, and then you have a problem. The second issue is there were criticisms along the 1 to 80, but that was meant to keep the door far open, so not to keep anybody out. And these are international data, so it's not the same in every country. And obviously you miss a very few patients in that way, which would be a problem in diagnostic criteria, but for classification that's fine. It's really a small group, but it does exist.
And today at EULAR, you'll be speaking in one of the Meet the Expert sessions on still no lupus against just adding up criteria. Can you tell us a little bit, for those people who won't be able to join, what kind of the key points of that will be?
So this is a bit of an experiment because in the same setting we haven't done it. But the idea is to start discussions on what is lupus and where do you think a patient does have lupus or not, to get away from, maybe that's even worse in Germany and Austria, this really counting 1, 2, 3, 4, and then that's lupus. We don't really need that anymore, and it doesn't really make sense. Question is, do you have clear parameters that say lupus? How specific are they? And what is something where we have a bit of issues at the moment with outside evaluation of the criteria? There's an attribution rule. So the ACR criteria, for example, say psychosis if you don't have that, that, and that. The SLIC criteria do the same with many of the items. But if you would do that completely, that would be a huge roll of paper. You can't do that. So there's one rule that says, like in diagnosis, count it only if there's no more likely alternative explanation. Now, when you have an anti-CCP positive patient in front of you, don't count the arthritis because it's very likely RA, it's not going to be lupus. That seems simple in the patient in front of you. But if you have patients with RA as the control population in a database, people forget about attribution. So they count it as if the RA was lupus arthritis, and then you get to much lower specificities. And I think that's also a teaching point for a diagnostic approach, which I think is for most of us even more important than the criteria, in the sense of trials come after you made the diagnosis and not before that.
Great. Well, thank you very much for answering my questions today. I hope you enjoy EULAR this year, and thanks for summarising the exciting things that we have to look forward to.
Nice talking to you. Thank you.
My pleasure. So I think that was really interesting. It was good to be able to put some of those questions to him. And in the Meet the Expert session afterwards, we were able to work through a number of different cases, which really highlighted the difference in the classification criteria that have been used. It's interesting that we sometimes look at these things on a daily basis in clinic, but it does really show the strength of the new EULAR ACR criteria, in particular for enrolling patients in trials with lupus, and with trials now showing more success. I think this is good evidence of how good the criteria is. I think one of the other exciting areas in lupus today was in the bench to bedside session, looking at complement. Mert and I were both there, and this was a really interesting session in that we know that complement is important for lupus, but abnormalities within complement biology have been highlighted in a whole array of autoimmune rheumatic diseases as well. This is now starting to excitingly show its way through to a therapeutic target, and we've seen drugs like eculizumab being trialled in lupus and antiphospholipid syndrome. Mert, what did you think? What were your main takeaways from that session?
Yeah, Chris, it was really nice session, and David Jane overviewed the possible therapeutic targets in rheumatic disorders, and he briefly summarized his study, avacopan study, and we all know avacopan is non-inferior to glucocorticoids in ANCA vasculitis, and the interesting point is avacopan group is significantly better in terms of patient-reported outcomes. And I don't know, what's your opinion about this, Chris?
Yeah, I agree. I think it was a really interesting finding from the study, and Professor Jane was showing how they used the short form questionnaire in a number of their studies, and interestingly it did show better health related quality of life outcomes in the patients treated with avacopan, and I think that's really interesting because it asks us as to why this is it due to the effects of steroids? I mean, I don't know what you think about whether there's anything else that could be contributing to this.
Yeah, definitely, I think so. And after David Jane, Dr. Radin from Italy presented their latest work, which they showed that the low complement levels in the first trimester predict disease flare in the lupus pregnancy, which was a network meta-analysis. And Chris, what's your opinion again?
Yeah, so I thought it was a really interesting study showing that they followed up the complement levels throughout pregnancy. It's definitely something I think clinically we'll all take into account when we see patients with lupus who are pregnant, just to keep a close eye on complement C3 levels. And
Serena, I know that you were at the guideline session.
Yes, you're right. I was in the EULAR recommendation updated session, and I was in particular in the session on management of ANCA-associated vasculitis, and this was a very interesting session. There were 17 statements. I am not going through all the statements, but I'm going to focus on therapeutic ones. First of all, the news is that they separated EGPA from MPA and GPA vasculitis because since 2016 there were many studies about the EGPA, and so if you have a patient with a severe GPA or MPA, you should treat him with a combination of steroids and cyclophosphamide or rituximab. But if you have a relapsing patient, you should choose rituximab. So it's quite nice. And also in maintenance therapy, you should choose rituximab over azathioprine. There is a difference with the old recommendation on vasculitis. Another interesting point was on steroids. steroids, you should taper rapidly steroids for your patient. They give us a protocol. They started with the dose of 50 or 5 milligram daily. It depends on body weight. And then you should rapidly taper over 4-5 months until 5 milligram daily. And then there are many other items, or for example, about prophylaxis. You should use trimethoprim sulfate metazoldol for many infections, in particular for pneumocystis jirovecii pneumonia infection. And also another interesting point was about ANCA antibodies. You should use antigen specific test and not immunofluorescence, because there are many other studies about it. And also for treatment changes, don't focus on ANCA antibody levels, but focus on disease activity scores. This was interesting. And I know that Rudy is going to the EULAR recommendation session like me. So Rudy, please, could you summarize the other recommendations?
My name is Rudy Shukla. I'm an NIHR Manchester BRC funded clinical research fellow. I work at the Centre for Musculoskeletal Research at the University of Manchester, United Kingdom. So I've just stepped out of the EULAR recommendation session, where most of the recommendations for RA have remained unchanged, but there are 3 big highlights to report. EULAR continues to recommend first-line use of glucocorticoids with methotrexate. However, there is now a focus on rapidly tapering and discontinuing glucocorticoids as quickly as clinically feasible. The second update is about first-line use of biologic DMARDs and JAK inhibitors. EULAR now recommends use of biologic DMARDs and suggests that JAK inhibitors can be used first line, taking into account risk factors. There is a list of risk factors that have been published this time. And finally, the third big change is about tapering. The focus remains on tapering and discontinuation of glucocorticoids and then dose reduction of biologic targeted synthetic or conventional synthetic DMARDs. I also attended the ultrasound session on monitoring disease activity in rheumatoid arthritis. 3 points to report from that talk. The first one being rheumatoid arthritis. The first one being ultrasound evidence of joint inflammation provides evidence for us to continue treatment for patients rather than de-escalate. The second point, ultrasound can help with patient adherence and improve this further. And finally, it highlighted the role of ultrasound in considering interventional procedures in rheumatology. That's it. Thank you for your time. This is Rudy Shukla signing off from the show floor. Back to you guys in the studio.
Thank you very much, Rudy, for giving us that information hot off the press from the recommendations session. Now, there was, following that recommendation session, there was the plenary abstracts later on in the afternoon, which, as always, contained a huge variety of the many different abstracts that are submitted to EULAR each year. I'd like to focus on 3 of the abstracts, which were actually on rheumatoid arthritis, but on the aspects such as comorbidities and also factors that are associated with outcomes in disease and also development of the disease. So the first one, which really caught my attention, which was quite striking, was a study done in just over 11,000 patients looking at the effect of depression on mortality in rheumatoid arthritis patients. And this actually found, using prescriptions of antidepressants as the proxy for definition of depression, that depression actually increases the mortality risk in patients with rheumatoid arthritis by 6 times, which I found quite striking and surprising, and actually has a real impact, I think, taking away for my clinical practice. And we know from a growing body of evidence the impact of mental health comorbidities in this cohort of patients, and I think that really brings home that we should be sort of addressing mental health comorbidities in our patients when we review them. The second plenary abstract I'd like to highlight actually looked at air pollution on the development of not just rheumatoid arthritis, but also other autoimmune diseases. So this was a study from Italy, actually, in a large cohort of patients, just over 80,000. And they found that chronic exposure to high levels of pollution actually can increase the risk of particularly rheumatoid arthritis, connective tissue diseases, and inflammatory bowel disease by up to 10% over time, which again, this is a very good example of socioeconomic factors and geographic factors influencing disease outcomes, which we may not necessarily think about when we see someone with the disease. And finally, something which I actually do use in my day-to-day practice, there was a presentation from Elsa Bosworth on the SMILE RA program from the National Rheumatoid Arthritis Society in the UK. And I know that, personally speaking, many of the patients which I see really find NRAS a really good source of information and help. And the SMILE RA program really comes it actually has come at a good time in terms of looking at EULAR recommendations when we look at the fact that they released the self-management guidelines last year. And this SMILE RA program really encourages patients to give them more information about their disease, particularly at diagnosis, and also gives them a bit more information about sort of how to manage a flare, how to manage their pain, and different members of the multidisciplinary team who may be involved in their care. And so I think it's a really relevant and important piece of work for the care of our patients. Now, speaking of rheumatoid arthritis, Rudy's been very busy today. So he actually conducted an interview with Miles Lewis, who is involved with the rheumatoid arthritis guidelines. And I think it would be really interesting to hear what sort of highlights and nuggets of information he had to share with Rudy. So let's see what he had to say.
We have the pleasure of speaking with Dr. Miles Lewis, who's just given his abstract presentation in the RA etiology, pathogenesis and animal models session. Thank you for joining us, Dr. Lewis. So could you tell us a little bit about the R4RA trial and what you hope to achieve with this study?
Absolutely. So R4RA is a multi-center biopsy-driven randomized control trial which started a whole number of years ago. And Queen Mary's the host centre for the trial, but it includes a lot of centres around the UK as well as Europe. And within the trial, the patients were randomised to receive either rituximab or tocilizumab. And perhaps the most important thing about the trial was that all patients received a synovial biopsy prior to entering the trial. And so really the purpose of the trial was to test the hypothesis as to whether if patients had low levels of B cells within the joint, would that lead to them not responding to rituximab, but instead respond better to tocilizumab? And our first paper, which was published last year in The Lancet, demonstrated exactly that, which was that if patients had low levels of B cells in the joint, then they did respond better to tocilizumab. And I think one of the most important findings that we demonstrated in the Lancet trial was that the measurement of B cells was more precise if you used RNA sequencing. So we had previously developed a 71 gene module which we used to measure the amount of B cells within the joint. And it was when patients were stratified with that B cell RNA sequencing module that they demonstrated reduced efficacy to rituximab, but enhanced efficacy to tocilizumab.
It's clearly a pioneering study and it's a great example of stratified and personalized medicine on show. What was the advantage of this specific cohort and then the crossover design that your study has?
Thank you. So I think in the second paper that's just recently been published, we did an extensive analysis of the RNA sequencing data from the synovial biopsies. And so this is a really unique cohort to have synovial biopsies in a randomized trial setting where all the patient clinical characteristics, response to treatment have been carefully documented. This is a unique cohort. And So that enabled us to do a really in-depth analysis of the RNA-seq data. And the advantage of having the crossover design was very useful because we realized that there was a group of patients who had failed both drugs. Now, because the entry criteria for R4RA is in patients who had previously failed anti-TNF, this means that this small group of patients had now failed 3 of the major biologics. And clearly, when R4RA was conceived, other novel treatments such as JAK inhibitors and so on had not been developed. But at the time, that meant that the major classes of biologics. And it's still an important result. So when we looked at that group of patients that had failed both rituximab and tocilizumab through the crossover design of the trial, we could see that not only did they have a clear gene signature with over 1,000 genes identifying that group, but when we looked more closely at which genes there were, we could see that those genes linked to particular patterns of fibroblasts. And so we then linked that to the single-cell RNA-seq data from the AMP consortium in the US, and we could see that it was the fibroblast subtype, which is characterized by being DKK3 positive, which was associated with being refractory. So, I mean, our view is this is an important new finding. It suggests that patients who have got high levels of DKK3 positive fibroblasts could well be refractory to multiple biologics, and they probably need an entirely new class of treatment to be developed for them.
Thank you for summarizing the main results of your study so well and giving us an idea of what it means for biologic response and refractory rheumatoid arthritis. So thank you so much for joining us.
You're welcome. Thank you.
Thank you very much, Rudy, and to Miles Lewis as well for sharing that with us. Unfortunately, that's the end of our coverage from day 1 of the EULAR 2022 Congress. Do please join us tomorrow when we will be covering more highlights. I'd be interested to know from my colleagues what they're looking forward to tomorrow. Matt, just one thing that you're looking forward to tomorrow?
I will look for a French national vasculitis research group's VEXAS study.
Oh, yes.
Yeah, and I hope to talk with Dr. Benjamin Terrier and make a quick interview with him.
Okay, that would be really excellent, I'm sure. And Serena?
Yeah, I'm going to lupus nephritis section and also the management of pregnancies in autoimmune rheumatic diseases.
It's a good follow-on from today as well.
Yeah.
And Chris, what are you looking forward to?
So, I mean, there's lots of great lupus stuff happening.
There
some
is.
great lupus presentations, some fantastic posters, and I'm very lucky to have an interview tomorrow morning with Professor Michael Ehrenstein and Dr. Mohammed Shibli from UCL, who have recently completed the BEAT lupus study combination of rituximab and belimumab. I'm looking forward to finding out all about that trial and what they're finding.
Brilliant. And I personally am looking forward to an EmuNet Present session tomorrow afternoon on the importance of patient involvement and the involvement of the multidisciplinary team in research. And specifically, I'll be talking to Ricardo Ferreira, who's one of the keynote speakers at that session. And so I do hope you'll be able to join us for that and also for day 2 of EULAR News tomorrow evening. Thank you very much for joining us, and we will see you tomorrow.